I suppose this is the last lecture that you will be having, Abby? Okay. When do you have end of posting exam or quiz? Next week? Next tomorrow? Okay. And I guess that you're ready now, having been exposed to all the information. Why are you not ready? Eh? Why are we not ready? Is it that we're not teaching people well, or what?
We are not teaching us well.
Eh?
We are not teaching us well.
You are not teaching us. I don't understand. You're not teaching yourself.
The seminar.
Okay, people are not
Was teaching us.
People are not presenting. People are not presenting seminars. And that's true, because the first lecture that I had with you was supposed to be a seminar, but nobody was prepared. I ended up delivering the lecture, which is not what it's supposed to be. Because when you read some of these things and deliver them yourselves, you're armed with more information. Anybody can learn anything these days. So today we'll have a topic which says ethical principles in psychiatry. Right? Ethical principles in psychiatry. Is that a topic? You have the lecture schedules now, but what are we looking at today? Neurocognitive disorders. No, that's not what I have here. You know, these lectures are shared. I'm supposed to take you people on ethical principles in psychiatry. But if we're able to finish early, then we can now touch other aspects of your curriculum that has not been touched. So when we talk about ethical principles in psychiatry, what we mean is the set of rules and guidelines that direct the practice of psychiatry such that the patients will be able to get the care they need with their rights and aspirations met by the clinician. I'll still give you notes as usual. I hope the course rep gave you the last notes. Yeah. Okay. So just like in any profession, you have ethics, you have principles guiding the practice of that profession. You know, guiding the practitioners, guiding the kind of care that is given to the customers or people that seek services. So every profession has principles, ethical principles. So, and now ethical principles in psychiatry are not too different from what you have in medicine. Are they taught you ethical principles in medicine? Okay. When did they teach you that? Okay, community medicine. So we are still going to be talking about those ethical pillars, but there are going to be modifications, and I understand you know the reason why there are going to be modifications, because many of our patients they don't have the capacity, to make decisions concerning their care. Not all of them lack that capacity. Some, especially those ones that have psychotic disorders. In psychotic disorders, we have impairment of reality testing, you have impairment of judgment, you have impairment of insight. That people that are having these conditions don't even know anything is wrong with them. So if you leave them like that, most of them will tell you that they don't need the care. Most of them will tell you, they are being forced to be treated when nothing is wrong with them. So, but at the end of the day, you still have to treat them as clinicians. And so That is why the ethical principles guiding the practice of general medicine might be different, or you might have some modifications when you're talking about psychiatric practice. So one of the ethical principles that we'll look at is beneficence. Beneficence, just like the name is, offering care that benefits your patient. And of course, that is the sole aim of medical practice or clinical practice, to offer care to your clients, the care that will benefit them, the care that will alleviate their suffering. So whatever you're doing should be geared towards offering care that is acceptable, offering care that is able to alleviate the sufferings of your patients. So for instance, a patient who has a psychotic disorder, maybe schizophrenia, comes to your clinic and you've evaluated the patient and you've made a diagnosis of schizophrenia. So what you have to do is to offer treatment, biopsychosocial treatment, which is aimed at alleviating the psychosis. So that is that. Then the next one, we are still going to revisit them because there are some considerations that we are going to be looking at for each of the ethical principles. So just like I said, the beneficence is offering care that is beneficial to the patient. And of course, it means that you have to be knowledgeable as a doctor to be able to offer a care that is beneficial. For instance, somebody that comes in with schizophrenia and you're not able to make the diagnosis, you say it's depression, and you start to give antidepressant. You see that that ethical principle is defeated because the care that you're offering is not beneficial to the patient. You're treating something else. And if care is not taken, you are even causing harm. And that takes us to the next ethical principle, which is non-maleficence. Non-maleficence. So in non-maleficence, you are supposed to, while you're offering your care that is beneficial to your client, you're supposed to offer it in such a way that you reduce the risk of harm. You reduce the risk of harm, or you don't outrightly harm your patient. So now in psychiatric practice, we understand that many of the psychotropic agents can have some form of side effects, right? So literally, if you give a patient a medication that results in significant side effects, one can say that it is a harm. Do you understand? But at the end of the day, you have to balance things. You balance beneficence against non-maleficence. For instance, typical antipsychotics are known to cause extrapyramidal side effects, right? Whereas atypical antipsychotics are known to cause metabolic side effects. Then the same thing with other psychotropics like SSRIs. What's the commonest side effects? Okay, what is the commonest sexual side effect of SSRIs? What? For men. They didn't teach you that. You didn't do psychopharmacology. Did you do psychopharmacology? Was there any lecture delivered to you on psychopharmacology? Are you sure? It's in your curriculum now. So one of the commonest sexual side effects of SSRIs is delayed ejaculation. So now, if a patient comes to you that is suicidal, a young man comes to you suicidal, and you make a diagnosis of severe depressive disorder, and by the principle of beneficence, you're supposed to offer an antidepressant therapy, right? So, and now the patient tells you, but I've been treated in the past, I've had this episode in the past, and I was treated with SSRIs, maybe the person goes ahead and mentions a particular name, paroxetine or fluoxetine, and I found it difficult to enjoy sexual activities with my wife. So what are you going to do? Because now that sexual side effects to the patient is like harm. Is that not? So what are you going to do? So these are the ethical dilemmas. But as a matter of fact, you need to weigh the pros and cons. You need to weigh the beneficence and non-maleficence. And where do you think the weight tilts to? Sexual function and overall mental health. Which one should you give priority? Overall mental, yes. You explain. Somebody is disagreeing. It depends on someone. No. Like the scenario I created, a patient walks into your clinic very depressed, suicidal, has had multiple episodes in the past, and you want to offer SSRI treatments, and he tells you, oh, I have been treated with this in the past, and I experienced significant sexual difficulties. So what are you going to do? Yeah, it's a dilemma. That's why I'm creating this scenario. But now look at the global picture. The global picture is that if somebody is severely depressed, you need to tackle that first. Because even the person that is severely depressed does not have sexual interest. You know, one of the cardinal features of depression is loss of sexual interest. Did I not teach you that? What are the typical signs? What are the typical symptoms of depression? You have low mood, low energy, loss of interest. Now, these are the cardinal ones. You have reduced appetite for food, reduced appetite for sex, feeling of worthlessness, feeling of hopelessness, suicidality, loss of all those things. Now, somebody who is severely depressed, do you think that person on a normal level is going to be interested in sexual function? Do you understand? So you have to find a way of explaining to the patient that this is the key thing. If your mental health is okay, that then you now start talking about sexual function. Now, some of these SSRIs, some of them have more sexual side effects than others. So if sexual problem continues to be an issue, you can switch the patient to another drug that has less side effects, or you add another drug. There's a drug that we call bupropion for patients that have significant sexual side effects from SSRIs. At times we'll add bupropion for them to ameliorate that side effect. And some of these sexual side effects, some of them are transient. Do you understand? So that can also be one of the things that you can tell the patient, that with time, that those side effects would wane down. Do you understand? You see how you navigate it now? Because at the end of the day, the most important thing for you to do at that particular point in time, yes, you have to recognize that there is a potential harm, using the psychotropic, but the benefits, that's the beneficence, outweighs the non-maleficence. So, but the one that is not good is to offer a care that is unacceptable to the patient. Maybe somebody comes with mild depressive disorder, you go and give antipsychotic, and the patient develops maybe tardive dyskinesia. You're liable. You know what tardive dyskinesia is? And in most cases, when people develop tardive dyskinesia, it can be permanent. It can lead to permanent disfigurement. Somebody that presented, for instance, with just mild depression, and you go and you misdiagnose the person. And that can increase the risk of litigation. Did they teach you about the 4 Ds of medical malpractice? Because based on these ethical principles, it's not just about, yes, your aim is to primarily offer safe treatment to the patient, treatment that is acceptable, treatment that will alleviate the suffering of the patient. But you as a clinician, you also need to play safe. Do you understand? You need to protect yourself, because liabilities are increasing. People are increasingly aware of their rights. Some of you, I don't know, how many of you are writing USMLE? How many of you want to port? Who is Chemele? Okay. Okay. Who is, are you the decision candidate? Okay. So people are increasingly becoming aware of their rights. In fact, abroad, you have some of these people that once a patient is coming out of the doctor's consultation, they say, how did he go? Did he treat you well? Do you have any concern? Lawyer undergo and other things. So if you're not careful, you see that you can lose your license even when you didn't mean to hurt the patient. So that is why we have 4 Ds of medical negligence or malpractice. First of all is duty of care, or duty, some people call it duty to care. It means that there is a relationship. Maybe somebody, if a patient comes to you and for instance you open a folder, clerk the patient and make a diagnosis and start treatment, you've established that contact. You have a duty to care for that patient. Do you understand? That's one. So before you're said to have committed medical negligence, one is that there has to be duty to care for the patient, meaning that you've established therapeutic relationship with that patient. Now the second D is dereliction of duty. Dereliction of duty, meaning that you didn't do what you were supposed to do. Dereliction of duty, that's the second D. Now the third D is direct relationship between dereliction and dysfunction. That dysfunction could be side effects, it could be death. So these are the main things. So once you've established that relationship, you need to be very, very careful. It's not just that, oh, this patient has psychosis, you load the patient with the highest dose of antipsychotics. That patient might even die from it. So, and you see that in that kind of case, you have caused harm. That is non-maleficence. And again, as a doctor, it is better to recognize your limitations. Like now, when you people graduate, you are general doctors, you've not specialized. But based on the clinical postings that you've had, psychiatric postings, at least is believed that you should be able to manage, for instance, minor mental conditions and all that. But you should be able to tell yourself the truth. Do I have the knowledge? Even if I have the knowledge, is my knowledge sufficient to be able to offer this patient a safe and acceptable care? If the answer is not, we have to refer. Because once you establish that contact and you begin to sure they said is you can give injectable, you just bam. Before you know it, patient develop side effects. And again, some of these side effects, it's not as if they are permanent, they can be managed. It has to do with experience. So if maybe you start treatment and somebody develops side effects and you know that you cannot manage it, you have to refer. Because if the patient gets permanent disfigurement or significant disfigurement from that dereliction of duty, you are liable. You can be sued for medical negligence. So what we are saying now is merging the beneficence and non-maleficence is that in as much as you're supposed to offer care that will benefit the patient, that will alleviate the patient's suffering, you should be able to do that within the safe limits, not to cause significant harm. Even if there is harm, you should also have a way of alleviating it. Just like some of these psychotropic related side effects, they have ways that you can manage them. And that takes us to our next one that talks about informed consent. Informed consent is another principle. What is informed consent? What is informed consent? Okay, so that is that. Now, informed consent, just like I said that the ethical principles guiding psychiatric practice are almost the same as the one guiding the general medicine. but you have modifications based on the peculiarities of the patient. Now, the decision, informed consent. Consent is somebody allowing you to do what you're supposed to do, giving you permission. Now, informed there means that this decision that the person is making to allow you to treat them should be based on the knowledge of what he stands to benefit, the possible risks or harm. Then you also have to provide options. For instance, if you're treating somebody who has a psychotic disorder, you have the option of using 4th generation antipsychotics, 2nd generation antipsychotics. It is also expected that you relay to the patient or the family members, these are the differences. Maybe 4th generation antipsychotics might be able to give you faster response, but they come with risk of extrapyramidal side effects. 2nd generation antipsychotics, are equally effective, but the rapidity of response might not be as good as you have in 1st generation antipsychotics. But the risk of side effects, like motor side effects, is reduced. But however, these antipsychotics also have the risk of metabolic syndrome. Do you understand? So you explain all these things. And for instance, if you are managing a young lady who is on the big side, coming with first episode of psychosis, it's very important that you educate the family members, even the patient, especially when the patient is being discharged. That's 2nd generation antipsychotics, even though they have the less likelihood of movement related side effects, but they can make you grow big and all that. So, and you see that some of them might tell you, please, I don't want to be big, especially if it's somebody that has not gotten married. Do you understand what I'm talking about? So these are the considerations. But if you just go and prescribe, and tomorrow the person comes down with obesity, hypertension, and all those stuff, the person will tell you it's the drug that you gave. I remember I told us about the 4 Ds. In the 4 Ds, duty to care, the relation of duty, relationship between the negligence or duty to care to dysfunction. So he said, since I started taking these drugs that have been big, in fact, my boyfriend has left me. What will you do? So see, these are the things. No, you have to explain to the person the diagnosis, the management protocols, options, and allow the person, depending on the mental state of the person. It's not all mental conditions that the person loses the capacity to make decision. If somebody comes with maybe mild to moderate depression, and is the person that presented himself, you still have to explain. Don't look at all of them as people that are psychotic. Not all psychiatric patients are psychotic. Because I know that you might be thinking that you see when somebody is very aggressive that will be saying all these things. Those ones that are able, to give you that informed consent, you have to explain to them, and they will be able to make their choices. Now, for those that do not have the capacity to make informed consent because of the severity of their illness, then you have to take informed consent from the family relatives or family members or whosoever the significant caregiver is. So the summary of the whole thing is that for informed consent, it has to do with the patient's mental state, the nature of the illness that the patient has. If you think that the patient's illness is not severe enough to impair the capacity for informed consent, you have to explain everything, give the person options, and guide the person in making choices. That is informed consent for somebody who has capacity. Now, for people who do not have capacity, like people who are severely mentally ill, psychotic patients, people with schizophrenia, they are -2. -2, like somebody who has not reached the age of 18, is a child. Just like I taught us during our lecture in child and adolescent psychiatry. Most of those people are going to be presented to you by family members, significant others, mothers, parents. So the informed consent that you're going to get will now be from them. Is that clear? So that's that. Then next one is autonomy. Autonomy. autonomy is also related to informed consent. So what's autonomy? At least in a general ethical principle, what's autonomy? Who can help us? Cost rep. Autonomy. As it regards ethical principle in medicine. Sit down, you don't need to stand up. Yes. Yeah. That kind of independence to run your life, to take decision concerning whatever that happens to you. So, a typical example is people that are in Jehovah's Witness. You know they don't accept blood. They don't accept blood products. You are laughing. Is there anybody here? Okay. So they don't accept blood products, even at the point of death. Do you understand? And now you have to respect that. I'm talking about general medicine. You have to respect that. You're supposed to use maybe colloids, crystalloids, and all those, and avoid blood products, even at the point of death. And you know that person has a capacity. Do you understand? The person is that decision is not influenced by mental illness. If you look at the person's chronology, they will tell you, okay, this person was born into Jehovah's Witness. This has been their practice. So even when the person is losing blood, you're not permitted. The person will even tell you, do not transfuse me with blood. The person has the autonomy, and that autonomy is absolute. Now, it's different from somebody who has, for instance, a psychotic ailment, who comes into your clinic disturbed, agitated, shouting, fighting, destroying things. And you try to reason with the person that, that we are going to inject you, It's only in this part of the world that you see some health workers, they will just start administering treatment. Before you administer any treatment to anybody, you have to explain to the person. Even when you have the injection, you have to say, they will ask you, what are you holding? You owe them that responsibility. Your sign. That is what it is. And if you go there and make mistake, they will seize your license. So the person confronts you, like, what do you want to? You want to inject me with poison? So you've joined them in the conspiracy. Maybe the person is deluded, and the family members bring him, and you're trying to inject the person. So you've joined them in the conspiracy. You want to kill me. You've brought out poison to end my life. I have the right to decide whatever that happens to me. You cannot inject me. If you inject me, I'm going to sue you. Somebody in a psychiatric patient can present that way. What is the person exhibiting? Autonomy. Now, but autonomy is going to be compromised in that kind of situation, because the person has become a danger to himself and to the society. So he loses that autonomy. He loses that capacity to determine what happens to him, because he's laboring under the influence of mental illness. So in that kind of situation, you see that autonomy will have to be relegated, and you now take up the principle of beneficence and non-maleficence. Beneficence is to do something that ultimately benefits the patient, whether or not he sees it as such. And non-maleficence is do no harm, or don't allow the patient to do harm. Because if you allow the patient, what will happen? Maybe the patient starts fighting, and before you know it, they start beating the patient. And in that process, the patient can even be mocked to death. So the principle of beneficence and non-maleficence will now take upper hand, downplaying the principle of autonomy, because at that particular point in time, the patient does not have the autonomy. Is that clear? So that's another one. Then you also have fidelity. Fidelity is another ethical principle. So fidelity has to do with dependability, constancy. You establish a therapeutic relationship with a patient as a doctor, as a clinician, as a psychiatrist, as a psychologist. Already that patient, there is already that deep relationship, because now psychiatry is about disease of the mind. So as maybe some of you that are going to practice that, a lot of patients are going to open up a lot of issues, deep issues that maybe he has not even told to people. so that the person will be able to get care. So as the patient is opening up all these things, trust is built. Anytime the patient has issue, maybe the person will call you and all that. So now in that fidelity, for instance, maybe you book an appointment, you tell the patient, I'm going to see you in the next 2 weeks. You give the patient date and all that, and that day you're nowhere to be found. That is your breaking fidelity. And of course, if you continue to break that fidelity, the patient is no longer able to trust you. The patient feels that you're not dependable. It's going to affect the therapeutic relationship. Because some of these illnesses are psychological. In fact, some of them, there's something that is called transference and counter-transference. I don't know whether they taught you that in psychology. Transference and counter-transference. Now, transference is about the emotional attributes or psychological attributes that the patient has on you as a clinician based on their previous experiences. A patient who had no father figure, who was raised in a dysfunctional home, or whose father or mother died while he was still very young, who was shown no love, that patient might come in with a lot of dependence. In his mind, he feels that this father figure, once that relationship is established, he now begins to see you as a father figure, or maybe as an important person in their life. That is the way, psychological or psychical, that's the way the patient views you. That is the relationship. So in transference is about how the patient views you. Now in counter transference is about how you view the patient. I give you a typical example. Maybe as a psychologist or as a psychiatrist, you've seen some troublesome patients, or patients that even challenged you, and you now form it in your psyche that many of these patients are troublesome, and somebody else comes and that person now looks like your former patient. They've come again, this one is most likely going to give me trouble. Before you know it, you get biased. Do you understand it? So that's transference and counter transference. So the emotional attributes that the patient has towards you, in terms of how he views you, how he sees you, maybe as a father figure or as an important figure in their life, and how he relates you, that is transference. Now counter transference is the other way around, and all these things are very important in therapeutic relationship. If the patient sees you, for instance, as a father figure, as somebody who is going to bring an end to his suffering, he will already trust you, and now you are not dependable. You don't maintain fidelity. You don't show up for consultations. You don't show up for clinics. You treat the person with levity. Definitely that therapeutic relationship is going to be lost, and it's going to pain depending on the transference that is playing out. You see that now, while we are discussing this, there's also another related principle: boundaries. Creating boundaries. Note it down. Creating boundaries. Just like in general medicine, there is a limit to which your relationship with the patient is expected not to cross. Do you understand? Because just like a relationship between a young lady and a male therapist, something like that, a young lady who is unmarried and a therapist or a psychiatrist, and now there is a transference playing out. This female patient sees a psychiatrist or sees a therapist as a father figure, as somebody who she will always run to anytime she has issues and all that. So now, if you don't regulate that kind of relationship, it might spill out to something that will be difficult for you to manage. Maybe before the patient, any little thing the patient calls you in the middle of the night.
So the psychiatrist is married.
Maybe the psychiatrist is not married too. Do you understand? So it can go either way. So you have to be able to maintain boundaries. Like a patient calls you as a therapist or as a psychiatrist, around 10 p.m. Maybe you're with your wife or something. Say, hey, I'm having headache, oh, this and that. And your wife is like, what is happening? You see that kind of thing. So you should be able to sensitively tell the person, please, I would encourage you to book an appointment. Or please, can we leave this in our next session? Something like that. You have to be able to create that boundary. Now, secondly, accepting gifts. Accepting gifts. Maybe in your consulting room, a patient gives you a bundle of dollars. You accept? Banana. So now some of these things, if you want to follow Western principles, ethical principles, you're not supposed to collect it. You're not supposed to collect it because it might blur that, you're making the patient feel as if they owe you. Do you understand? You're doing your work. So it depends. Now, these ethical principles, these ethical principles, you have to put into consideration the cultural background. Do you understand? The cultural background. Just like I said, in the Western world, you can be sued for that. Accepting money, you can be sued for that. And now, remember, you're handling people who are believed to have some mental health issue. How are you sure that that person that is giving you that gift is in her right state of health? How are you sure that that person is not having mania? Have they not taught you mania? Part of the symptoms is overspending, overgenerosity. Doctor, you're my all and all. Since I knew you, my problem as a fact, please take this bundle of money.
What if the patient is like fully well, like he has undergone what the session does?
Well, you need to apply discretion. I'm just telling you what is standard. Do you understand? In fact, it's even easier, it's even better to accept from family members. Do you understand? If they push too hard than to accept from the psych. I'm not talking about general medicine. No. I'm not talking about general medicine. I'm talking about psychiatric patients. I told you that these ethical principles are the same, but there are modifications. If it's a general medicine, maybe you are an orthopedic surgeon, you fix somebody's limb, and the person is so happy, and the person gives you a car key. Why won't you? You can accept it now. You can, but they can still say you are exploiting the patient. But it becomes more serious in the mental health field, because at the time that the person is giving you that gift, did you assess the mental state? Even if you assess the mental state, there could be bias because you're the one assessing it. Your eye is on the gift, so you can say everything is okay. Do you understand? So these things are potential areas where somebody could face litigation. So you should be able to use your discretion and what is obtainable in the place that you practice, your cultural milieu and all that, to be able to draw that line. Now, another one is a doctor befriending or having sexual relationship with a patient. That one is, I'm talking about general medicine. What do you have to say about that? What were your thoughts? It is wrong. It is wrong because no matter how you look at it, as a doctor, if you as a doctor relating with a patient, there is a power imbalance. Do you understand? There is a power. The other person is at a disadvantaged situation. Just like a lecturer dating a student, is it ethical? It depends. What? It is normal, but is it ethical? If the university community gets to know about it, what do you think will happen? There are so many things that can go wrong. Let me tell you. No, there are so many things that can go wrong. A lecturer, you're dating your students. Now, what do you think will happen when marks are being awarded? You can leak the question paper to the students. I'm telling you this thing so that these things, there's no depends. When it comes, is when you enter into trouble. When you enter into trouble, that's when you know that all this depends will not, because there are issues. You're dating a student that you're lecturing. Now, how are we sure that you will not leak the exam to her? How are you sure you're not going to mark? Wait now. How are you sure you're not going to mark her, award her all the marks, even when she doesn't merit it? How are you sure? Maybe tomorrow you people have problem, quarrel. How are you sure you're not going to come back and fail her? The girl can even turn back and say, it's because we broken up, that's why you failed me. No, these are the real issues. And once these are ethical issues, and once they come up, once you're reported, you now start explaining. You go explain tire.
No evidence.
But is there? Teach the wife.
Yes.
But if it happens, if that one is exceptional. That one is exceptional. It's a marital relationship. Now I'm talking about, now it's just like me. Maybe I'm the exam officer now, and I approach a lady. You know that I'm an exam officer, and maybe I have all the, and you believe that if you don't agree now, maybe you'll mark me down. What do you think will go on in your mind? You'll be jittery. You'll be jittery because you know that if I don't agree now, are you sure this person will not mark me down? Are you sure you will not go and paint me black among other lecturers? So these are the issues. That is why, even if, like some people say that you cannot befriend your patients, your current patient, but maybe when the therapeutic relationship is no longer there, maybe your long-term patient, that you can do that. But there are still controversies. You know, in ethical, what appears ethical to you may not appear ethical to me. So these are some areas of controversy that you have to be. Why we are saying this thing is that we have different values, we have different backgrounds. But what we are saying it is that these are some areas, some gray areas that you have to be careful about. Apply caution, the highest possible caution, because you might make mistake. The lens that you're, like now, if I write this is 9 here, I see it as 9, but from there you're seeing it as 6. So anything that will make you, unless maybe you like controversy. You know, there are some people that like controversy. Most of these online bloggers, they like controversy, they thrive in controversy. But medicine has not gotten to that. The controversy that you enter, you won't even know whether your license will go from there. So these are the issues. These are some boundaries, ethical boundaries. Don't date your parents, especially your current patients. Don't date your patient, especially your current patient, because there is a power imbalance. You're likely to misuse it. Do you understand? So these are some of the ethical principles. Then let me check more. Veracity is another ethical principle. Veracity means you shouldn't sugarcoat things. For instance, a patient comes to you, you make a diagnosis of a major mental condition like schizophrenia. Maybe this patient is brought to you by family members, and the family members tell you, oh, this patient is very emotional, please don't tell him the diagnosis, it will weigh him down. So what are you supposed to do? And maybe when the patient has recovered, the patient comes for checkup and asks you, doctor, what is my diagnosis? Why is it that every time I'm taking drugs, what is my diagnosis? Will I ever be off these medications? What are you supposed to answer the person? You see that these are ethical principles. The family members have already told you, this person might not be able to handle this, that. Just like diagnosis of cancer. It can be traumatic. That's why we are taught, I don't know whether they've taught you that, how to break bad news. You have to learn, as a clinician, you have to learn how to break bad news. Because a patient that you're managing might die, and maybe the family members are anxious and they are waiting. Do you just come out and tell you the person has died? Is that how you do it? So you have to learn how to be able to manage people's sensitivities and emotions. So, and now family members have told you, please don't tell the diagnosis. Diagnosis. You know, mental illness is seen is a stigmatizing thing. Nobody wants that label. You have schizophrenia, you have this, you have that. Say, please don't tell, please keep the diagnosis. Don't tell her, she will break down more. And now you stabilize this patient is coming for checkup, receiving treatment, and one day the patient asks you, doctor, why is it that every time I'm taking these drugs? What is my diagnosis, sir? What are you supposed to do based on this principle? Some of these things are common sense. So what should you do? Nobody's okay. What are you going to do? Fair lady, what will you do? As a psychiatrist, somebody is coming, taking medications, doesn't know the treatment and wants to know the treatment. The person is an adult, but you recall that during the first presentation, the family member said, don't tell her the diagnosis, she's too soft, she can't accept it, it will weigh her down. What will you do? Say that thing that is in your mind now. What will you do? Yes. Yes. The principle of veracity mandates you to tell the person. Do you understand? Depending on the situation, just like initially, they said don't tell. But now this patient has responded to treatment, coming for checkup. Now, if you hide that diagnosis, what do you think will happen? At a point, the person may not cooperate with you again. The person may not, because the person is an adult, has the right to know the information, and you know that schizophrenia is a lifelong ailment. So how do you explain that she continues to come for checkup, taking her without knowing? So it's at that particular point in time that you open up. You have a mental condition called schizophrenia. It's not your fault. It's as a result of circumstances, beyond your control. It's as a result of genetic influences acting on environmental factors acting on genetic influences. And the way this illness is in such a way that you have to take drugs for a long period of time. So the patient needs that psychoeducation, needs that veracity, so that he or she will have the conviction or see the need to continue to come for checkup. Do you understand? So regardless of what they are, okay, please answer the question. Okay, you have a question. Okay.
What if the patient is fully recovered, but then still feel like I'm not ready to still feel okay, I've taken my drugs, I've completed my drugs, I'm not meant to take drugs again. But in the eyes of a doctor or just a family member, listening to the advice of the doctor, then you're telling the patient, no, that this thing that you're doing, you're meant to be always doing. This patient refuses because she can see that she's actually fine. What would you based on ethics?
Okay, yeah, it's a very important question. Now, depending on the climate again, I tell you what obtains abroad. Now, if a patient has been managed for a mental ailment, maybe a severe ailment like schizophrenia, the patient has gotten well and is now coming, for checkups and all that, and suddenly says, I don't want to take these drugs again. I'm okay. Why should I be taking drugs again? You leave him abroad. Do you understand? They have a lot of right issues. Because they will tell you that at that particular point in time, him not taking the drug, it doesn't constitute any harm. But if he's in this part of the world, you understand, family members who understand that certain illnesses can relapse, maybe schizophrenia or bipolar, can compulsively bring the patient to the hospital, and the patient can be treated. Do you understand? But in the new mental health law, they are not really straightforward. They are of the opinion that you should treat, that's involuntary treatment, when you have adjudged that if you do not treat, that the patient is at the verge of relapse, and when the patient relapses, the patient is going to be at imminent danger to himself or others. Do you understand? So that's it. So it depends on the culture. But abroad, maybe in Western world, you can't compel. If the person has, because at that particular point in time, the person has regained the capacity or has regained the autonomy. So the person can tell you, I'm okay, I've been taking this drug for long, I'm okay, nothing is wrong with me. The person can even tell you, I have stopped this drug for a long time and I'm still okay. So at that particular point in time, you cannot compel the person. Even yourself, it can be argued. It's just that if the chances of relapse are high, maybe the person has relapsed several times in the past when he stopped taking his medications, and you believe that if the patient is not treated, that the patient is at verge of relapse, or maybe the patient is already giving you signs of relapse, you can compulsively treat. So that's that. So for veracity, you're supposed to be open to the patient, provided that what you're, of course, you have to weigh the pros and cons. Now, this one will be different from maybe somebody who, maybe in general medicine, somebody who is diagnosed of breast cancer, maybe stage 4 breast cancer that has metastasized, and the person has fragile emotionality, and the family members tell you, please, this patient is still anxious, please, can you delay breaking this bad news? Now, if you break this bad news, that the patient's state will deteriorate. What do you think you can do? You may reason with the family members, do you understand, and make the environment stable, because now before you break bad news, there are things that you're supposed to do. You have to ensure that the environment is conducive enough. Do you understand? And again, some will tell you, you have to ask the patient how much he wants to know. You know, some people like to live in denial. There are some people that will have terminal ailments. They don't just want you to say it. So the patient also abroad, abroad there are so many laws. The patient also can determine, as long as he has the capacity, can determine to tell you, please, I don't need this information. Just do what you're supposed to do. Do you understand? So in preparation for breaking bad news, you also have to find out what the person knows about the ailment. You can say, what do you know about cancer? Do you understand? And again, you can also find out to what extent the person wants to know. There are some people that will not want you to go into that, because the more you're telling them, the more they are breaking down emotionally. They say, doctor, just do what you're supposed to do. So these are the dynamics. So it's something that you have to use your discretion based on your experience, based on what is obtainable, in the area where you practice, based on the culture, and based on the guidelines, standard medical guidelines. All these guidelines, they are different. The guideline in America is different from the one you have in UK. Even though they may be similar, but there might be some peculiarities. Now, another one is confidentiality. Confidentiality is very important. It's very important, especially in general medicine. But you know that there are conditions or situations where you break confidentiality. Can you tell me one of them? The lady on glasses. In which situations can you break confidentiality as a doctor? Not just in psychiatry, in general medicine. Does anybody know? Sit down.
Maybe a terrorist, like give the information that patient nearby police.
No, okay, let's go to general medicine. Let's say
if the person has a disease that can be contagious.
Yes, infectious diseases. You're supposed to report to. I'm telling you the truth. You're surprised. Somebody has TB now and refuses treatment. You're supposed to report to health authority. Somebody has HIV, a man contacts HIV, and this one, although this one is controversial. A man, maybe you're a family doctor to a couple, and one comes to you confessing you that he has contacted HIV, but he doesn't want the other person to know. What do you think he will do? You're bound to disclose the information. You first of all encourage the person to open up, because now if you don't disclose the information, the other person is at risk of getting infected. Do you understand? So you encourage the person to disclose the information. But if the person refuses, as a medical practitioner, you are bound to tell the other person. So these are what if what? No, that is where you break confidentiality. I'm telling you, in situations where you break confidentiality. Do you understand? This thing is what? Yeah. So your rights will end when the person's safety. I don't know. There is a way they put it. So if the right that the patient has is going to affect the other person's safety, then that right has to be done away with. Just like infectious diseases, maybe Ebola now, Ebola virus, or which other one, Lassa fever. Do you understand? Somebody comes to you and confides to you that I have Lassa. I have Lassa. Please don't tell my family. I want to go back with to them. Do you understand? You have to. You have to be detained, Daddy. So that's it now. That's it. So confidentiality is sacrosanct, but whenever that confidentiality is going to affect the person's safety and safety of people around, then you have to downplay that. So now, okay.
Can confidentiality be breached when you're managing a patient and you're seeing that this person is at the last stage of this illness and is going to die very soon?
Okay.
But all this while, the patient says, don't tell my family member about what is happening to me, don't tell them about my sickness, but they come around, but they don't really know the diagnosis, and this patient is about.
You shouldn't break it now. There is no harm to the patient. The patient doesn't want them to know the diagnosis. The patient is already dying. Now, telling them the diagnosis is going to change the management. It's not going to change the management. So you obey the patient's wish. So, but you only tell them maybe it's not a terminal thing, and the patient is at the verge of dying. Maybe nobody to help. Do you understand? But if disclosing the information to them will not add anything, the patient is already dying. So now there's something that is called Tarasov's rule. Tarasov's rule. So now this Tarasov rule was made as a result of the aftermath of an incident that happened in California, some time ago. There was a certain patient called Prosenjit. Don't worry, I'll give you the notes. Podla Prosenjit. Now, this patient was having a mental illness, most likely a psychotic disorder, and it happened that the patient was a student, and he was a kind of trying to befriend a particular lady, a classmate. So, and the lady kept on rebuffing him. The lady was not accepting him. So now, in one of the therapy sessions that he had with the therapist, he confided in the therapist that he felt slighted, that the lady did not turn him down, that he would kill the lady. So now, but the therapist did not make a significant, even though the therapist tried to discourage him from carrying out that act, but the therapist did not take extra precaution to report the patient to the authorities, and also to report to the person that was being threatened. So at the end of the day, the guy, Podla Prosenjit, killed Tashiana Tarasov the lady. So now the therapist was sued. So, but at the end of the day, the court now ruled that it is the obligation of the therapist or the psychiatrist or the clinician to warn and protect the person that is at risk. So that came about, the duty to warn and duty to protect. Now the duty to warn is that you would have to tell the person. Maybe somebody comes to you and confides to you that I'm going to kill somebody, that this person has been my trouble, has been a thorn on my flesh. I'm going, in fact, I've concluded plans to shoot him. It is your responsibility to inform the person that is being threatened, and even to inform the authority, maybe the police, so that the person will be given adequate protection. So this is one of the situations where you breach confidentiality. Do you understand? Tarasov rule. So it was the aftermath of that incident and the judgment associated with it that gave rise to this Tarasov rules. You have Tarasov 1 and Tarasov 2. So Tarasov 1 is duty to warn, Tarasov 2 is duty to protect. Is that clear? So that's one of the situations where you breach confidentiality. I think we've okay, now justice is another one. Justice is another ethical principle. Justice has to do with equitable distribution of resources in the medical setting, maybe in hospital setting. I give you a typical example. Maybe you have a private clinic and you have different groups of people coming to you. Some are very rich, very influential, while some are commoners. Now, because you know that an important person is coming to consult you, you will tell the person to jump the line, because the other people are not going to bring money. That is breach of justice. Justice requires that as long as the other person does not have emergency, that when you attend to, when you don't attend to the person, there will be problem. If it's just normal cases, then you should be first come, first served. That's one. Then another one is triage. Triage during emergency. You know what I mean by triage? Just like in the accident and emergency, people come with multiple injuries and other people come with minor ailments. Do you understand? So justice requires that you have to attend to the person that has more urgent need. Do you understand? That's the problem. That is a place. That is if you're the principle of justice requires that you have to attend to the person that has more need, acute need. So if you go and attend to the governor or maybe whatever, like that's why I usually talk about, if it's Peter Obi, for instance, we know who Peter Obi is. That's the kind of things he preaches. He goes to Philistine and said you have to join the queue. Do you understand? It's just that our country, our values have changed. Do you understand? Some of these things, if this person you ask now, if you were abroad, you would not even ask it because you know the answer. Even governors, presidents, they live like commoners in some countries. So, that's why some of these principles, they are easily broken. These are the things that you have to know what is acceptable. What is acceptable is that you have to triage. No matter who is involved, you attend to people that have more acute need. Because if you're attending to somebody that has minor ailments and the other person dies, what will happen? They will still, lash on you. The public will still lash on you, especially this period where people have their cameras on and they are recording. Did we see what happened in Abuja, University of Abuja Teaching Hospital 3 weeks ago? You saw that, where they said they were not attending, they were videoing everybody and all that. So people are increasingly becoming aware of their rights. Gone are times where people, you can suppress them and they keep quiet. You might be doing that and be getting away with it, but one day only see will meet you and you see that the person will mess you up. So, initially the relationship between doctors and patients used to be paternalistic. Do you understand? Doctor was seen as all and all, whatever. No, it's no longer like that. Even when you have that ego, you need to be careful. And if like now where I consult, some of the places I consult, people who want to come in and they will tell you they are working in the hospital. I say, do you know what I tell them? Go and tell those patients there, beg them. Do you understand? Because if I tell you to come in, they will revolt. I say, go and beg the person that is, beg them that please, that you're working in the hospital, that I'm telling you the truth. Because I remember that there was a time that I was giving them that privilege, and next thing I heard that was that I was collecting money. Do you understand? That I'll collect money and reshuffle folder. So when after that incident, I said, no, even if just tell them, explain to them, and if they do that, many of them will accept. Do you understand that? Please let the doctor attend to me so that I'll be able to go back to they will accept. But when you do it because you know the doctor and all that, that's when they start quarreling. So all these things are about justice. Then you say? Okay, whether you can sue the now, if a patient violates you, and maybe a normal patient, I'm not talking about psychiatric patients. Do you understand? Maybe you're a general practitioner, and maybe because of all this who comes first or who doesn't come first, and somebody comes and people can do that and slap you and tear your this thing. Yes, the person can be sued, especially the hospital that you're working with. You report formally. Maybe you're working in a public hospital like this, and the patient violates you. You take it up and follow necessary legal processes, because you have to be safe to be able to offer care to your patients. So, and that is why is even contained in the code of ethics that if a patient is too unruly and you feel that your life is endangered, you can decide not to attend to that patient. I'm talking about general patients, not psychiatric. A psychiatric patient can spit on you. Though that's the extreme situation. That's if you don't do necessary sedation. Although they are not as dangerous as the public think, it's only about 1% of them that are dangerous, psychiatric patients. Sure, you went to MNN now. Did you go to see those patients? Did they attack you? But I'm sure. Okay, not yet. No. They are not as dangerous as the public perceives them. There's only a very few of them. So in justice, you're supposed to offer, care, to your patients without any bias. Without any bias. That's what justice is talking about. So I think we've exhausted many of them. Do we have questions? No questions. If you don't have questions, I'll ask questions. Okay, who is the class note taker? The note taker, where is she? Okay, you're the one. So, did you get everything? Can you summarize the lecture for me? Looking at your notes.
Ethical principles in psychiatry. These are guidelines that protect the practitioners and care that is given to psychiatric patients. We have beneficence, non-maleficence, autonomy, fidelity, transparency, counter-transparency, creating boundaries, veracity, impartiality, and justice.
Okay.
Then beneficence is talking about offering care that benefits your patient. Then non-maleficence is doing no harm to your patient. Then you talk about the side effects of the SSRI, delayed ejaculation.
So how do you? So each one you pick up, you explain it. Is there anybody that can do that? Who can do that? Okay. So pick up each one and explain it.
Okay, for beneficiaries, is offering care that benefits your client.
Okay.
And from what you discussed, it requires you as the clinician having the knowledge that you need to help your client so that you don't, in the process of trying to offer care, cause harm. That
Okay.
you also spoke about beneficent and non-maleficent.
Okay.
So non-maleficent is to do no harm. I also spoke about not allowing the patient to do no harm, or not allowing harm to come to the patient as well.
Okay.
I think you said it has 3 Ds. 4 Ds. Okay, I'm going to go to the relation of duty and
Duty to care, the relation of duty, direct relationship between the relation of duty and dysfunction. Dysfunction is the fourth one. Yes. So what did I say around that maleficence? I took time to explain it with examples.
Okay, you explained about side effects, for example, artists, generation, artists.
No, I just tie it to the concept. I explained all those things. I was driving at a point. Can somebody help her? Can somebody help her? Okay.
We said that if you do not have the right knowledge and skills to care for a patient, you should be fair and not try to manage what you cannot handle.
Okay.
For instance, when you're a house officer, you have basic knowledge of many different things, but then if you use a complicated case, you need to refer to the specialist to handle it.
Okay. So as to avoid harm. Okay. Is there any other thing? Explain the next concept.
Informed consent.
Okay.
Informed consent is stating all the facts of an illness or condition in patients and allowing them to make the best decisions for themselves when they have the capacity to do so. And not practicing the paternalistic model when
Yes.
they make the decision for the patient. Then autonomy.
No. I gave considerations on that consent. 2 considerations: when the person has the capacity and when the person doesn't have capacity.
So, for when the person does not have the capacity, you make the best decision.
Or you can get involved the family members or primary caregivers. Okay.
Then for next,
Okay, next person. Who else? Is it only females that are talking? The next concept now. Autonomy or cost rep.
You need to respect their rights. You don't take it upon yourself that, okay, since they don't accept blood and you go ahead and give blood, that means you are breaking rights. You're actually being a dictator or something. That was the instance you gave.
No, that's not the only instance I gave. You just gave the instance in general medicine, not in psychiatry. The fair guy, Chim. Your mind just okay.
I think we give the instance of in Western culture when a person is like, I don't take this drugs anymore. And if it's that the person is not fully in control of himself, he should not listen to what he has to say. But if it's that the person is to an extent stable, you can.
So the idea is that autonomy can be upheld in general medicine when the person has the capacity. And I gave the instance of Jehovah's Witness. They have the capacity, they don't have any mental impairment, and that has always been how they do their things. Now, the other one is when somebody is laboring under the influence of mental illness. Do you understand? And the person is refusing treatment that is supposed to benefit him and not cause him harm. That you have to go ahead. And that is where we have the concept of involuntary hospitalization. involuntary hospitalization. A psychiatric patient, many of them are brought to the hospital against their wish. You still go ahead and treat them. You understand whether or not they are saying is good for them or not. So, what else? Next one. Next one. Okay. Okay.
You talked about having like someone's father figure, there is a way the patient sees you, so you have to uphold that.
Dependability.
So you also talked about transference and counter-transference. And transference is the emotional or psychological attributes that the patient has on the clinician based on their past experience.
Yes.
Which is how the person takes you. Yeah. And then counter-transference is how the clinician views the patient based on past experience as well. And we also talk about clinicians having bias towards patients based on past experience.
What do you mean by clinician having bias? Explain it more.
Okay, like for example, patients that were aggressive in the past, yes, like that. So some clinicians might decide that for that reason.
Okay, that they've seen, they see a new patient as this patient looks like somebody that will give me trouble. Let me just, that kind of a thing.
Yes.
Okay.
So boundaries. Spoke about having a limit to the relationship between clinicians and the patients. For example, we are not accepting it from our patients. We are not accepting it because it can be like we are exploiting them. It can also be that we are being biased as well. We are not fully
Or making the patient feel as if they owe us.
yes, making the patient feel as though they owe us. Then another thing that
And it can lead to litigation that you're exploiting the person. Are you sure that the person has a good this thing, mental health to be able to?
at that point you also cannot access their mental state.
And objectively,
Yes.
because of that bias.
And so you cannot date or have a relationship with your present patient because of the
Power imbalance.
power imbalance. Yes, so it can seem as though you are taking advantage of that patient. Also, we also spoke about channeling some conversations. For example, the patient is driving, or if patient calls you in the middle of the night, and
Maybe patient is becoming too familiar.
Yes, or speaking in an unprofessional manner, you have to channel it back to whoever. We spoke about veracity, where we said as a clinician, you are not meant to sugarcoat things, you are meant to explain to the patient and their family in this case how everything is so that they can know what is going on. And you should also learn we as doctors should also learn how to break bad news appropriately. Although you said in general medicine, you are meant to wait for a while, you assess the patient, like if the patient can handle it. So I
You have to
don't know,
prepare.
are you also meant to prepare the patient
You have to prepare. So bad news, the idea is that bad news is not something you do without thinking. It's not something you do spontaneously. Do you understand? You have to make sure, prepare the environment. The person is not somebody is still standing and panicking, and you start. Make sure that the environment is okay. Make sure that the person the person is in the right state of mind. Do you understand? Assess what the person knows about the illness or the condition. Then also assess how much the person wants to know. Do you understand? There are so many. You can go and read about how to break bad news. So you read it. It's a concept on its own, but these are some of the items.
Okay. Then we also spoke about confidentiality, which is the right to keep patient's condition like a secret or confidential unless the patient has given permission to divulge information. However, there are grounds where you can break confidentiality. in general medicine, for instance, in infection disease, and when someone else's life is at risk based on information you have, so you have to
I give an example. I give an important example. I might ask you that in your quiz. I give an important example. Tarasov rule. You have to mention Tarasov rule. So where you have rights to, you have duty to warn and duty to protect. Okay.
Okay, and the last one is justice, which is the equitable distribution of resources in management of patients, and it is especially seen in triage during emergency, where patients that radioactively injured are meant to be taken as priority before other patients. Thank you.
That shows somebody who is listening. Some people are not listening. It's okay. I think the absence of any other question will come to the end. Okay, so wish you well in your quiz.